Dear colleagues, this is a case of a soft cataract on a left eye, which you're gonna see starting the capsular axis, incising the anterior capsule using the knife, and then using the 25 gauge forceps. I'm able to fashion around pretty large capsular axis, 6.5 or 5.6, sorry, and closing it and finishing up the capsular axis, making the hydrodissection, using the hydrodissection cannula to try to rotate a little bit the nucleus inside the bag, and then having this left eye on a very deep socket, I prefer to use the left hand, non-dominated hand, and do the phacoemulsification, enlarging one of the paracenteses on the left side, and then using the chopper and irrigation on the phaconid, rotating a little bit more the nucleus inside the bag to free up the cortex, and aspirating a little bit the cortex on top of the nucleus, and then with this long chopper I'm fashioning a horizontal chop, engaging the equator of the nucleus, and then using the phaco tip, I'm embedding it a little bit in the middle of the nucleus, and the crack is propagating very easy, even though it's a soft nucleus. Again, rotating the nucleus inside the bag, and then repeating the maneuver, the horizontal chop maneuver again and again, and I'm able to have three more pieces of this nucleus cracked, and starting the phaco aspiration, basically, because being a soft nucleus is not gonna be used a lot of ultrasound in this case. It's just aspiration and a little bit of chopping, and the nucleus is coming out very nice and easy. A lot of BSS on top of the cornea, it's obstructing the view a little bit, but having this deep socket eye, it's better to have the phacoemulsification done on the temporal side. So training your non-dominated hand to do basically 80% of the dominated hand, it's always useful, and in this case I'm able to finish up the phacoemulsification pretty easy, and cleaning up a little bit the cortex inside the bag using the phacoemulsification probe, and then switching up through irrigation through the AC maintainer, and aspiration through the aspiration cannula. The last part of the cortex is getting out easily by this 23 gauge aspiration cannula, using the sandblasted tip to polish the posterior capsule. Will ensure a clear view through that optic the next day. Switching up the instruments and finishing up cortical removal and have a clean bag at the end. Using same irrigation maintainer in one side port and injecting the hydrophobic oil using the autosert system. The haptics are getting stuck to the optic, but using the chopper I'm able to place the entire IOL inside the bag, and at the end placing some myocol and air bubble and finish up the case. I hope this will help you in your practice also. Thank you for your attention.